Good afternoon. Welcome to the Thyroid Masterclass. Before we begin, I just wanted to remind you that we're going to have two masterclasses in April. 4th of April will be dedicated to reproductive endocrinology, and then we have a neuroendocrine tumor masterclass on Friday, 25th of April. I will remind you again at the end as well. If you could keep your microphones on mute and turn off your cameras during the talks, I'd be very grateful. You do not need to put your names or contact details in the chat for CME. There will be a QR code at the end where you can scan it and get your CME or CPD certificates immediately emailed to you. Thank you. So again, today we're going to have 4 clinician scientists at the forefront of their field, and we will hear about the latest developments and updates in thyroidology. It's my pleasure to begin the masterclass by inviting Dr. Sheba Jarvis from Imperial College London, who will be talking about management of thyroid disorders in pregnancy. Sheba, over to you.
Thank you very much, Professor Sam. I'll just share my slides. Okay, just get that into slide mode and I'll begin. Can you see those slides okay?
Absolutely, thank you.
Perfect. Okay, great. Well, thank you very much for inviting me to speak at this Thyroid Masterclass on thyroid disease in pregnancy. It's a large subject area and we'll be covering things like interpretation of thyroid function during pregnancy, thinking about levothyroxine replacement during pregnancy and overt hypothyroidism, subclinical hypothyroidism and its need, and briefly touch upon thyroid autoimmunity. We'll talk about diagnosis and management of hypothyroidism during pregnancy. So there's no doubt when we think about early fetal development, the fetus is very dependent on the maternal thyroxine levels. We know through these sort of that the fetus is jumping through these hoops, and it's only really about 14 weeks. The fetal thyroid is synthesizing thyroxine, secreting it at 19 weeks, and it's under control by the pituitary at 20 weeks. So needless to say, the maternal thyroxine levels are critical for the developing fetus, and thyroxine crosses over the placenta, especially in that first trimester, as does iodine. And obviously maternal hormone concentration is relevant here, but also there are loads of other factors that will be that will lead to sort of the levels of appropriateness in the fetus. So let's just go through altered thyroid physiology during pregnancy as a reminder. So we know that there are marked changes. Sorry, just move my thing. Marked changes during pregnancy driven by estrogen. And at the level of the liver, there's reduced hepatic clearance of thyroid binding globulin, increased synthesis, and overarchingly a raised total T4 and T3. There are changes in terms of iodine levels or increased iodine level losses in terms of from the EGFR changes in pregnancy. And we do want women to be taking an increased iodine intake of around 220 to 250 micrograms daily. We know that we need to consider the effects of the human chorionic gonadotrophin levels, so HCG, because clearly with its common alpha subunit to TSH, there is thyroid stimulating activity. So what we see is obviously a raised free T4, TSH suppression, particularly in that first trimester. And that's summarized in that pink box. We've got a 50% increase in thyroxine production due to a rise in the TBG, and thinking about the beta HCG effects on thyroid stimulation. And this is a very well-used diagram by Korovar from Nature Reviews Endocrinology, just to remind us of this key point. These dynamic physiological changes need to be considered when interpreting TFTs during pregnancy, which we know well. But let's just go through that. If we follow this green line, hopefully you can see my mouse moving. At the top, we've got high levels of T4, TBG going up, that peak in beta HCG, a suppression in that TSH in that first trimester, and we can see there's a downward shift in the TSH reference range, both the upper and lower limits of that normal range across pregnancy. And there are trimester-specific differences. And when you have twin pregnancies, you'll have a higher level of HCG and more marked effects. So key point 2, clearly TFTs are best interpreted thinking about those dynamic changes in pregnancy, those trimester specific changes, but also want to just draw attention to population-based understanding. So early studies in my red box here from 2007 onwards describe the first trimester TSH range, and we can see the upper limit of that was about 2.8. Later studies, which increased sort of our understanding within the literature, demonstrated in certain populations such as China, India, and others, and Korea, that actually the upper limit of that first trimester TSH range is much higher at 4, and so on. And this is an example test from an NHS trust elsewhere, looking at TSH levels according to that trust assay and looking at the first trimester, second and third trimester levels of TSH, T4 and T3. So in terms of this key point, we clearly know that dynamic physiology that we remember, but also according to the assay, according to your local population, TFT targets are best interpreted when we're making management decisions on the local trimester specific ranges. And if that's not feasible, then trying to look at similar populations or a similar assay. And if that's still not transferable, then it is recommended from the ATA guidance by Alexander et al. About using an upper reference range of TSH of less than 4, in terms of you saying anything less than 4 is likely to be normal. So let's look at a typical case of a pregnant woman with overt hypothyroidism. In this particular case, 32-year-old primate, known Hashimoto's thyroiditis for over 17 years on a 75 microgram levothyroxine dosing, which has been stable in the last 8 years. Last TFTs 3 months ago, very much in range with a TSH of 2.5 milliunits per litre, and is currently 6 weeks pregnant, and the GP calls for advice on dosing the thyroxine. This isn't that interactive with Menti, but mentally you can think about what might you do. You might advise an empirical increase to 100 micrograms of levothyroxine, knowing what we know about increasing thyroxine requirements in pregnancy, remain at the current dose, or organise TFTs and advise with the results. And I suppose the key point seems obvious. Ultimately, taking away the noise and the confusion, we're trying to prevent abnormal TFTs. We know how critical thyroxine is to support that pregnancy throughout. The neurodevelopment sequelae from the first trimester to be discussed in my next slide. So we want to mimic these physiological changes with using our exogenous T4. And it's a common problem in our antenatal clinic, with 0.5% of pregnancies complicated by hypothyroidism. So we know there are lots of reasons why this is important. The brain is clearly an important target of thyroid hormone with THR receptor expression at all stages of life, and that maximum vulnerability is here when we think about that first trimester, where you have neuronal proliferation, the onset of neuronal migration, and that dependence on maternal T4 levels. Subsequently, in the second and third trimester, there is ongoing neuronal development, of course. So it is critical that we get that right. And a lot of our evidence and concerns come from sort of worries about having inadequate thyroxine replacement, leading to cognitive impairment, developmental delay, low IQ, seizures, and other neurodiversity features. And a key study by Haddo and colleagues in the New England Journal of Medicine, a case control study, albeit with small numbers, demonstrated clearly at that point in these women that had a mean TSH of 13.2, that by 7 to 9 years of age, children born to mothers with such high TSH that were untreated hypothyroidism at that time in that study had 7 IQ points lower in those children. And that sort of, there's been a plethora of studies since, another one by Pop and colleagues that same year. So we know it's important, clearly, from a neuronal perspective. During pregnancy, we know that the TH receptor isoforms are highly expressed in placental tissue. They have important roles in vitro, affecting the proliferation, invasiveness, and viability of trophoblastic cells as the placenta is developing, and affecting all the vasculature and in the inflammasome and other mechanisms, as we're learning over the last sort of 10, 15 years. And there's obviously a higher instance of malplacentation in thyroid disease. And in this blue box, we can see some of those clinical outcomes from an obstetric point of view of miscarriage, preterm labour, placental abruption, intrauterine growth restricting in an SGA baby, preeclampsia and stillbirth being our key concerns. So let's think about our care approaches and considerations with hypothyroidism, with overt hypothyroidism. That is, we should be obviously making sure we have adequate preconceptual counselling, having stability with a euthyroidism, aiming for a TSH of less than 2.5, asking our patients to contact healthcare professionals when pregnant, and ideally checking TFTs early pregnancy. And ideally basing these dose adjustments on TFTs There is obviously a thought that actually a more pragmatic way of going forward, given that we know there's an increase in thyroxine requirements in early pregnancy around 20 to 30%, that would equate to 2 extra tablets, perhaps 2 days a week. And knowing the underlying etiology is of importance, because clearly if there's iatrogenic thyroid disease from surgery or radioactive iodine, you're likely to need an increased dose of thyroxine versus perhaps autoimmune conditions. In terms of monitoring thyroid function tests, again, by the trimester and population-specific reference ranges, 4 weekly until 20 weeks, and then per trimester, inquiring all the while of symptoms of under or over replacement. Predicting dose adjustments, aiming for a TSH in the lower half of the pregnancy-specific range. And postnatally, given we've hiked up a dose, we'll need to reduce that thyroxine and think about that typically by 2 weeks, 6 weeks postpartum. So I just want to bring up, there are a number of studies around replacement, empirical-based sort of increasing of thyroxine versus TFT-based. And I just wanted to bring attention to this trial by Sullivan and JCEM in 2017, briefly, only involving small numbers, admittedly, of 33 women, where they had 2 sorts of groups. A group where basically there was an empirical increase in thyroxine by 2 pills per week, according to the TSH levels, and then further adjustment of TFTs, versus a group, again, small numbers, where actually the thyroxine dosing was adjusted based on the thyroid function test done at that first visit, and then further adjustment on subsequent TFTs. And in both groups, for the large part, a number of women remained in that trimester-specific range. But interestingly, within the empirical group, and just to be aware of, there was a higher percentage of women with a suppressed TSH. This is only one small study, but just something to think about. And actually, in more recent years, from Tim Koroval's work in the Netherlands, we've been able to understand that it is very much a fine balance with treatment. And this is just, again, an excerpt of the paper, and would recommend reading it. And there was an association, sort of looking at the association between maternal T4, offspring IQ, and cerebral cortex volume measured by MRI. And looking at the maternal free T4, which you can see on the x-axis, around 8 to 16 weeks gestation, and basically saying that actually when you have higher levels of maternal T4, actually it's a U-shaped curve. So of course we're worried. We want to make sure that somebody is replete, we're within that trimester-specific range, but actually there is this over-treatment scenario that is not without risk, particularly from this sort of this new work in the last sort of 10 years. And there are other risks of over-replacement, of course, as well, from an obstetric point of view, such as IUGR, SGA, preeclampsia from that over-treatment scenario too. So it's something to consider, and we'll come back to that. So I'm next going to move on to subclinical hypothyroidism in pregnancy. And the older guidelines in 2011 or so suggested using a fixed cutoff to make that diagnosis and make a decision to start thyroxine in pregnancy using a TSH of less than 2.5 in the first trimester and 3 later on. This is defunct now because the guideline has been since updated. But I suppose the point to make using those thresholds, then actually subclinical hypothyroidism prevalence would be about 20% in the pregnant population using that cutoff. Based on some of those studies I showed you earlier in my slide deck around sort of looking at trimester-specific ranges, looking at the geographical and ethnic variation, there's a lot more data within the literature, and that led to the updated guideline of the ATA, basically saying actually using an upper limit of a TSH of less than 4 would be still within normal range and not necessitate treatment. And using that cutoff, that sort of still leads to quite high numbers, but it's SCH prevalence of about 3 to 13% using that particular cutoff. So just to bring some of that evidence on how things have changed quite dramatically in the last 10 years in terms of our understanding. But moving on to thinking about the sequelae of subclinical hypothyroidism in pregnancy. So what we're saying is if that somebody has a TSH, ideally above the trimester-specific range with a normal T4 and no symptoms, those are the people we're concerned about. If we didn't have a trimester-specific range, we should be using 4 as the cutoff. And the main concern around SCH sequelae in pregnancy is based on a lot of observational studies. In the blue box, you can see the possible complications and concerns if we didn't treat subclinical hypothyroidism. Miscarriage, where there's increasing evidence around this area, preterm labour, abruption, on others and some of the neurocognitive effects and the subfertility population and those with failed IVF and recurrent miscarriage and so on. But this screenshot from Negro et al.'s paper in 2014, a little bit old, but the point being made here is these were basically, each one is a study. It's very small, admittedly, but essentially the point I want to make is actually the definition of subclinical hypothyroidism based on TSH targets is variable across the studies. It's very heterogeneous. And then looking at this patch of sort of red being a significant association, orange being a no significant association, it is a bit of a mixed bag in terms of outcomes. So in that particular study, these various definitions of SCH, there were inconsistent findings. There have been some meta-analyses since, but just to be mindful of that data when we look at it. Thinking about SCH and neurocognition, there were two key randomized controlled trials. Again, in the time that I've got, just to brief you on those, there was the CATS-1 trial in Wales, led by Lazarus and colleagues in 2012, where basically this was about treating women with subclinical hypothyroidism or isolated hypothyroxanemia with 150 micrograms of levothyroxine, and they were started at a median gestation of 12 weeks, so quite late. And then when they looked at treated versus untreated and looking at child's IQ at age 3 as the primary outcome, there was no difference between no significant difference between the IQ of the offspring that were treated and those pregnancies and not, and no difference in obstetric outcomes. CATS-2, published in 2018, a follow-up from that study of 449 participants, at 9.5 years of age, again showed no difference in IQ or percentage of children with an issue with an IQ of less than 85. Again, making the point that levothyroxine was started a bit late at 12 weeks. However, the key thing to recognise is actually at this point in time, there was a more than expected incidence of ADHD symptoms and behavioural difficulties in children that had been overtreated with levothyroxine. And a USA study by Casey et al. In 2017, again, looking at randomizing women to levothyroxine versus placebo at around 17 weeks, again, quite late, showed no significant difference in cognitive outcomes for children at 5 years of age, or any changes in obstetric outcomes to add. So it is still unclear, but what is clear is that using this paper from Maraka et al., in terms of pregnancy loss, in this particular table, looking at odds ratio of adverse outcomes in terms of pregnancy loss, it is clear that actually treating subclinical hypothyroidism likely does have a role in those women. So I think the key point is, who are we checking thyroid function tests on in the first instance when we're making diagnosis of subclinical hypothyroidism? Well, obviously, if there's a personal history of thyroid disease, we're going to send off some TFTs, as listed in this particular table here. If there's an associated autoimmune disease, type 1 diabetes, systemic lupus, myasthenia, etc., sure. And subfertility history, then we would be thinking about checking TFTs, recurrent miscarriage, previous stillbirth, or a second trimester miscarriage. The next key point is we'd be treating women who have a TSH which is above that gestation-specific range. Sorry to labour the point, but that is of importance. And if that's unavailable, then we'd use that fixed cutoff as per new guidelines of 4, basically. And if we've started levothyroxine in this pregnancy, then after the pregnancy, we're going to need to stop and reassess and have a clear plan for what we're going to be doing in terms of the thyroid function tests after 6 weeks. Thyroid autoimmunity is a big area, and I'm not going to be able to do justice. But what I will say about this at this point is clearly thyroid peroxidase antibodies, different people have different methods of whether or not they check. But when we look at TPO antibodies, actually there is a overrepresentation of around 10 to 30% of the miscarriage population having TPO antibody positivity, with a higher risk of recurrent pregnancy loss and preterm labour. And that might affect our treatment thresholds as well. There have been a few attempts, though, to try and understand the impact of TPO antibodies. And what I will say is there are key trials. The tablet trial that we'll probably all know, a double-blind RCT, basically randomised women, 952 women who'd had miscarriage or subfertility to placebo or 50 micrograms of levothyroxine from preconception to the end of pregnancy. And their primary outcome, looking between the groups, there are others, but I haven't got the time to go through them. But the key point for live birth rate, there was no difference between the treated group who were euthyroid and TPO antibody positive, because there's quite a large literature base around miscarriage rate in TPO antibody positivity. The T4 Life study by Van Dijk et al. In Diabetes, Lancet Diabetes in 2023, did a similar study where they also compared levothyroxine to placebo, and that did not result in higher live birth rates in euthyroid women with a recurrent pregnancy loss in that study who are positive for TPO antibodies. So we do not advise the routine use of levothyroxine in women who are TPO antibody positive, even with that recurrent pregnancy loss, if they've got normal thyroid function. And that autoimmunity, it's clear TPO is present within the developing embryo and the developing milieu in utero. There need to be further studies designed around exploring that autoimmunity in other detail, because it simply isn't replacing thyroxine from the data we've got to date. So my last part of this talk, I'll go through thyrotoxicosis in pregnancy. So Graves' disease affects around 0.2% of that pregnant population. The key point actually is, though 10 to 20% of pregnant women will have a low and undetectable TSH in the first trimester, and that's a normal feature often with hyperemesis, which will resolve. So I kind of look at this when someone presents in the first trimester with abnormal thyroid function tests suggesting thyrotoxicosis. Is it's HCG versus TRAB, like a lot of us. So if it's new onset GTT, gestational transient thyrotoxicosis, that affects significantly more women based on what I've already said. There'll likely be no symptoms pre-pregnancy of thyrotoxicosis. They'll have a history of hyperemesis gravidarum, no or small goiter, no signs of thyroid eye disease or family history necessarily, and using ratios such as the free T3 to T4 be normal, and the TSH typically normalizes by the third trimester, if not earlier. New onset Graves' disease, much rarer in pregnancy, and often there'll be symptoms pre-pregnancy. HG is less of an issue. There'll be a family history, potentially of thyroid disease or autoimmune disease. They may have a diffuse goiter, signs of thyroid eye disease, some of the Graves' pathognomic signs, a free T3 that's normal or raised, and a raised free T3 to T4 ratio, and a suppressed TSH. Obviously, there are other causes as well that can lead to thyrotoxicosis in pregnancy at the bottom of my slide. I suppose the key point with gestational transient thyrotoxicosis, this does not require anti-thyroid drugs or any further management, but rather careful monitoring. So what are the risks of thyrotoxicosis in pregnancy? There are the maternal risks that we know, atrial fibrillation, cardiac failure, at which high mortality of thyroid storm, but admittedly that is very rare, visual deterioration. There are the obstetric concerns around miscarriage. 45% of patients, there's a risk of pregnancy loss without treatment. Preeclampsia, a fourfold high risk. Preterm labour, 1.7-fold higher, if not higher. Fetal risks, IUGR, so intrauterine growth restriction. We don't typically actually recommend fetal growth scans as routine, but that is a risk. Stillbirth, CCF. And there are the neonatal concerns you can see in that table as well. So our anti-thyroid drugs, when we consider this particular area, we know that we have carbimazole and PTU to be wrestling with. Of course, there's the definitive treatment, and the ideal situation with somebody with Graves' disease is that is treated with radioactive iodine with obviously no conception for at least 12 months going forward, or surgery if required. I'm not going to go into that at this point, but we'll just go through anti-thyroid drugs. So the issue with both are congenital malformations, and that is slightly higher, as we know, with carbimazole, and that led to an MHRA alert a number of years ago. So the key things that we're concerned around carbimazole include aplasia cutis that you can see in this diagram here, this scalp defect, choanal atresia, and other things. And there are dose-responsive effects with a higher dose of carbimazole. With PTU, we still have that agranulocytosis risk. The congenital malformations are still 2 to 3% in this population, affecting the urinary system, head and neck deformities. And there's also the risk in terms of the hepatic concerns with propylthiouracil, in terms of hepatocellular damage and liver failure. So again, limited on time, but just to bring up two key studies. A registry study in Denmark in 2013 by Anderson basically tried to look at the effects of anti-thyroid drugs at population level in terms of birth defect rates. And clearly the background rate is 5.4% here in this table, with PTU in 500 women that were prescribed PTU in the first trimester, there was an adjusted odds ratio of 1.66 and a higher prevalence of birth defects. That was higher still for methimazole or carbimazole at 9.1%. And actually, interestingly, there was a higher risk still if there was a combination of drugs. So if somebody had been on carbimazole, for instance, and switched to PTU in that first trimester, there were effects of both drugs. And that was an important thing to consider. And that's been followed up by a Korean study in 2018 by seeing colleagues, but looked at 2.9 million pregnancies with 12,000 pregnancies exposed to anti-thyroid drugs in the first trimester. And the bottom line is there was a higher prevalence of birth defects as expected with ATDs. And there were cumulative dose effects. And again, in this table, we can see the incidence per 1,000 for PTU, higher with methimazole or carbimazole, and that combination, again, a higher odds ratio. So in terms of thyrotoxicosis management and anti-thyroid drug choice, which drug? Well, I'm going to start with pre-pregnancy counselling is key to sort of trying to get stability and making these decisions. So pre-pregnancy, you'd probably want to switch people to propylthiouracil, ideally stabilising disease beforehand. In the first trimester, we tend to use PTU and switched in the second and third trimester to carbimazole if treatment is still required. It's a titration regime because obviously block and replace regimes are contraindicated in pregnancy. And if we're making that new diagnosis, we may start at something like 50 milligrams BD PTU. If in the first trimester, consider beta blockers. The aim is really to keep the dose as low as possible with anti-thyroid drugs in light of all of this new data that's coming through. So ideally less than 10 mg of carbimazole and less than 100 mg of PTU. Monitoring TFTs every sort of 4 weeks typically, or 2 to 6 weeks is sort of the range. Inquire about symptoms of under and over replacement as we would do. Follow up in a joint antenatal and obstetric medicines or specialist service. These dose adjustments that take place, we're aiming to maintain the free T4 in the upper half of the pregnancy specific range. Again, thinking about these importance of our assay being worked up for our particular hospitals that we work in. And in terms of the trajectory, many will stop because of those immunosuppressive changes in pregnancy by the mid-second trimester. There is a risk if we're stopping anti-thyroid drugs of a postnatal relapse. So patients need to be properly counselled about that and have at least a 6-week TFT check in the pipeline and their usual endocrine follow-up in place or a clear sort of safety plan. Fetal neonatal considerations, we know that with Graves' disease, there's transfer of the TSH receptor antibodies, and that's higher in Graves' disease. Having had a thyroidectomy or radioactive iodine, there's the likely presence of TSH receptor antibodies present anyway in pregnancy. So in that group of patients, even if they've had definitive management, we will check for them around 22, 28 weeks. They cross the placenta. If the TSH receptor antibody titer is 3 times the upper limit of that normal range, then actually we tend to, in our centre, organise an extra fetal scan at around 30 to 32 weeks to assess fetal heart rate, look for a goiter, because the risks are severe, aren't they? Tachyarrhythmias, intrauterine growth restriction, and hydrops vitalis, and at worst, mortality risk. We make sure our neonatal teams are aware of the maternal history, and babies get neonatal TFTs checked around 7 to 10 days postpartum. In terms of breastfeeding, we know there is transfer of carbimazole and PTU into the maternal milk and into the neonate, but actually it's much higher with carbimazole at 0.5% versus 0.025 in PTU. But we do know that sort of up to doses of 20 mg of carbimazole, there are very few issues in terms of the small literature when we sort of look at that, and safer still in PTU. So I'm getting close to running over time. So what I'm going to say is thyroid test interpretation in pregnancy and these decisions that we're making around what we're doing with levothyroxine, whether or not we're going to make a diagnosis of subclinical hypothyroidism and initiate treatment, needs to be trimester specific to your population. There's clearly an undisputed need for thyroxine to support pregnancy and overt hypothyroidism and to maintain a good level. The treatment of FPH is associated with adverse pregnancy outcomes, but the evidence that levothyroxine improves outcome is still scanty, and I'm sure there'll be future studies. The titration of LT4 to concentrations at the higher end of the normal range may lead to overtreatment. So it is really about monitoring, isn't it? And an awareness of that U-shaped curve from Tim Korovar's work. Graves' disease, when well controlled, there's typically good outcomes. Consider antithyroid drugs at the lowest possible dose and watch for that postpartum flare. And I'd say, apologies for the typo, there's no convincing evidence that treatment of TPO antibody euthyroid women with levothyroxine improves fertility, pregnancy outcomes. Thinking about the tablet, the T4Life study, and another one called Postal in 2017. So we do need more mechanistic understanding that's required. So I'm going to thank you for your attention. This is a screenshot from the Embrace reports, just to sort of highlight the need for pre-pregnancy counselling so women are fully informed. And I will stop there. Thank you very much.
Thank you very much, Sheba, for a very clear and lots of practical take-home messages. If you have a couple of minutes, I'd be grateful if you could look at the chats and see if you can add a few. I know you have to go and you're on take for I really appreciate it. In time, I'm going to move on to our second speaker, Professor Ketan Dhatariya. It's a real pleasure to have Professor Dhatariya, Professor of Medicine at the University of East Anglia, who's well known to you for having led the development of multiple guidelines nationally, internationally, but today he's going to talk about management of thyroid emergencies.
Thank you. Thanks, Amir. Thanks very much indeed. Right, I'm just going to try and share my slides and hopefully go into presentation mode there as well. Hopefully you can see that.
Very clear, thank you.
Thank you so much. Okay, so thanks for inviting me. I appreciate that most of you who know who I am think of me as a diabetes doctor, but actually I do both, and I do think of myself as an endocrinologist as well. So I was asked to talk today about thyroid emergencies, and I appreciate that this is a subject that many people think that they would know what to do when they meet these conditions, but I'm going to go through some of the information about what's available, what's not available, and what we should be doing in the two most common. So these are my disclosures, nothing of which have got to do with anything I'm talking about today. So these are things I'm going to be limiting myself to today. So I'm really going to be talking about the things that, even though these things are really quite rare, these are the things that were really most common when we talk about thyroid emergencies. So profound thyrotoxicosis, thyroid storm, and mixed edema coma. I'm not going to talk about the things that are potentially different and potentially more contentious. The thyrotoxic periodic paralysis, of course, much more common in various parts of the world, and sight-threatening Graves' ophthalmopathy, which of course is a thyroid emergency, but will most frequently present to the ophthalmologist and not to the endocrinologist, although the endocrinologist may be asked for their opinion. And also, one of the things I'm not going to be talking about really today is amiodarone-induced thyrotoxicosis, partly because that doesn't often present as a true thyrotoxic emergency or a hypothyroid, but it may present as a hypothyroid coma. But again, the nuances of whether this is type 1 or type 2 amiodarone-induced thyroiditis, I'm not going to be talking about today, because I think there's quite a lot to talk about just within the profound thyrotoxicosis, thyroid storm, and the mixed edema coma. So let's talk about the spectrum of thyrotoxicosis. So thyrotoxicosis is, of course, very common, and those of us who do this day in and day out and see this in clinic will see the people in our clinic, and many of you will see people who are diagnosed most frequently in primary care because they present with the classic symptoms, as you see there in the middle column, with a bit of sweating, just feeling a bit hot there, jumping around. And we're all familiar with those people who come to the clinic and who have either been not appropriately treated or have been undertreated, or for whatever reason have chosen not to have their treatment until they see somebody in the clinic, and they're just twitching in their chairs and they're writhing around, and you see them and you know that this person is clearly thyrotoxic. And of course, the classic symptoms of tachycardia and loose stools and so on, as you see in the middle column there. For thyroid storm, which again is, I would have to say, is probably relatively uncommon, but when you see it, you recognize it, and you need to recognize those things. So these people will not just be heat intolerant, they will be hyperpyrexia, they will be sweating, they will be, often they'll have a degree of psychiatric symptoms. We get this. You get the classic description of those people who have got psychosis. So they've got they've got a loss of reality testing. You know, they'll be on the top of a building saying, "I can fly. I know how to fly because I can." And of course, that's that will trigger your if somebody presents with psychosis, then of course thyroid function test is something that you need to do to exclude hypothyroidism. Of course, at the very extreme, they'll be present with seizures and coma. But with the thyrotoxicosis, with the tachycardia, you can get high output cardiac failure, as we know, atrial fibrillation, which it's not limited to people with thyrotoxicosis, of course, but having AF, you just need to think about it. It's the constellation of symptoms together that you need to be thinking about, whether you need to, or of course, people who are unwell you need to think about whether this is thyroid related. But again, as I've said, the hepatic dysfunction, we've just heard from Sheba as well about talking about whether this could be medication induced, but often just having thyrotoxicosis on its own can lead to significant liver dysfunction. And one of the other things we need to think about is not only many of the things I've discussed are things that you need to do on examination, but actually it's also taking a history, which is important because there's often a history of a precipitant, which I'll come on to, and there is an appreciable mortality with thyroid storm. And these are the precipitants but this some of the precipitants. So these are the conditions leading to a rapid rise in plasma thyroid concentrations. So it could be that the individual, and I see this every now and again, that you say, well, I feel fine, thank you, and I don't need to take these drugs anymore. I spoke to somebody on the telephone the other day who's currently being in prison, and they've got thyrotoxicosis, which has been quite resistant, but he felt so well on his dose of carbimazole, he decided he didn't need it anymore. And of course, his next thyroid function test showed he was significantly thyrotoxic. And when I spoke to him on the telephone, it was clear that by his pressure of speech and all the other things, you could just tell that I had to try and convince him that he needed to take his medication. Radioactive iodine. Now, again, this is one of the things. When you consent people, you should let them know that there is a very small risk that you will precipitate a worsening of their thyroid symptoms, of their thyrotoxicosis symptoms. But of course, if they are on anti-thyroid drugs and have been maintained and are euthyroid prior to their radioactive iodine, then the risk of that happening should be very low indeed. But if they've not been treated, there is a risk of them developing worsening thyrotoxicosis and a precipitation of thyroid storm. External beam radiotherapy, not just to the thyroid, but in the head and neck cancers, of course, because of that destructive thyroiditis, you can potentially precipitate a rapid release of thyroid hormone into the circulation. Of course, iatrogenic, if somebody decides they wanted to start taking loads and loads of thyroxine for whatever reason, because it used to be a drug associated with weight loss back in the 1970s and 1980s, before, well, even though it was recognized that would be harmful, but people still may want to do that. Giving iodinated contrast for whatever reason in somebody who may have been iodine insufficient beforehand can suddenly cause the release of thyroid hormone and can precipitate thyroid storm. And of course, if the surgeon goes in and starts squeezing that thyroidizer in the neck, and of course increase the release of those thyroid hormones. The other group of people who can get thyroid storm are those conditions that are associated with subacute or non-thyroid illness, so non-thyroid surgery. So someone rummaging in the neck for whatever reason, parathyroid surgery, for example. Having an infection, having a viral infection, as we all know, people can have transient thyroiditis, which can give people quite marked thyrotoxicosis. And of course, after a few weeks, they can become profoundly hypothyroid. But in those few weeks, they can develop quite profound thyroid storm. Stroke, having venous thromboembolic disease, as you see here, childbirth, as we've just heard from Sheba in her excellent talk, DKA, a subject close to my heart, as many of you will know. All of these things, for whatever reason, can precipitate thyroid storm. Now, there are a number of scales which have been published to try and allow non-specialists a way of differentiating whether this person has clearly got thyroid storm is at risk of impending thyroid storm, or that a thyroid storm is unlikely. And you can see here, this is one of the more famous ones from Leon Wartowski and colleagues. So looking at temperature, central nervous system effects, gastroenterological or hepatic function, looking at tachycardia, heart failure and AF, and so on. Now, I have to be honest and say I've never had to use one of these, because when you see somebody, it's often blindingly obvious that this person is really, really not well. But those are available to you. And similarly, there's one from Japan, again, which uses a combination of those features, similar to the Wartowski scale I've just shown you, where you have to think about whether, but maybe less. It's just if you've got a combination of these things, yes or no, rather than giving them an actual score. And you can see here it's thyrotoxicosis with either CNS manifestation or heart failure, tachycardia, and so on. And I'll leave you to read that. But again, for many of these things, you can say, you know, I think this person's got thyroid storm. Does it ultimately make a difference whether you make that diagnosis or not? Well, it depends, because it depends on how friendly you are with your intensive care team, because that's what these people will often need. The reason is because the prognostic, the prognosis for these conditions, as I've mentioned, the mortality can be really quite high. And this is just one study published earlier on this year in the JCNM, showing that mortality can be as high as 1 in 20, 1 in 25 people, so 1 in 20, 20 in 18 people, showing that the prognostic indicators are a low BMI, so you've lost a lot of weight fairly rapidly, you've got cardiovascular compromise, you've got low ejection fraction, that high output cardiac failure, you are already hyperpyrexial, and you've got an Apache score which is greater than 12, where somebody wasn't following the guidelines on the previous management of thyrotoxicosis. And so the Apache score, which is used quite commonly on intensive care units as a marker of physiological distress and how far you are away from normal physiology, to show that actually your prognosis can be guarded, and you need to treat these people potentially much more aggressively. I want to go back to say, how do these drugs work? How do anti-thyroid drugs work? So this is just a quick schema, which I'm sure many of you will be familiar with. But just as a reminder, why do we use the drugs that we use? So going through here, if you look at what happens in the basement membrane, you've got the sodium iodide symporter taking in iodine into your cells, into the thyrocyte, lining the follicles, the follicles within the thyroid. You've then got the thyroglobulin, the protein within, which also then is organified under the influence of TPO, thyroid peroxidase, and hydrogen peroxide, which then causes the tyrosine residues to be organified with iodinated, to give you either monoiodinated thyroglobulin or diiodinated thyroglobulin. The TPO antibodies then further work on this to add more iodine onto those, to you either get T3, triiodothyronine, or T4, which has got 4 iodine molecules attached to it, of course. Now, if you then got this iodinated thyroglobulin, it undergoes proteolysis. You get rid of the mono and diiodinated thyroglobulin, and the release of the free T4 and T3 into the circulation. And what you need to remember is that carbimazole and PTU inhibit that thyroid peroxidase, preventing the iodination of those tyrosine residues. So that's how the drugs work. In the circulation, of course, PTU also acts on the peripheral conversion of T4 to T3, and that's why it's preferred use in thyroid storm. So you've got different aspects of the management of thyroid storm. So you've got these are the things that are directed towards the thyroid gland. So the inhibition of new thyroid hormone synthesis. So as I've mentioned, you can give carbimazole or methimazole or PTU, and they're both available as oral or liquids, and so you can give them either orally as a tablet or NG if you need to. Then there comes the inhibition of thyroid hormone release, and that's when you can give iodine or potassium iodide Lugol solution, which inhibits the colloid proteolysis, which is the end bit that I meant right at the end. Or you can use lithium as well. That's the effect on the thyroid itself. But if you then want to work on the peripheral, stopping the conversion of T4 to T3, of course, you can use PTU because it inhibits type 1 deiodinase. You can use glucocorticoids as well for the same reason. And there is an effect of beta blockade to do the same thing. The benefit of beta blockade as well, as of course, that it prevents, it can slow your heart down. So all of the other side effects that you get on the cardiac compromise, which of course is also very useful. And then you can, in the very extreme circumstances, get rid of extra circulating thyroid hormone, either by using the plasmapheresis or by preventing the intrahepatic circulation by using cholestyramine, which binds to the bile acids, of course, binds to the iodine and thyroid hormones in the gut and prevents reabsorption. But those are fairly extreme. Of course, you need to treat the other things that are going to affect the individuals. You treat the hypothermia, being careful to avoid aspirin, because aspirin binds to thyroid binding globulin, therefore releasing free hormone into the circulation, which actually can make things worse. So you just use paracetamol. Of course, we need to cool these individuals because they're quite dehydrated. You give them IV fluids and electrolytes. And if they are cardiac compromised, you need to give them vasopressors. And of course, if they're in heart failure, you need to balance that with diuretic use. They can become hypoglycemic, so you give them glucose and thiamine as necessary. And of course, because of that long list of precipitants, that's where the history comes in, and you need to treat the underlying precipitant. Do you ever go for emergency surgery? Wow, that's an interesting point. Your surgeons will really not thank you. These individuals, if you do take them to theatre, they will bleed and bleed and bleed. And as a result, they'll have a high perioperative mortality. So I had a patient last week who had to go because they had very resistant thyrotoxicosis and they had young children. They couldn't, even though they were on 60 to 80 milligrams of carbimazole, they couldn't have radioactive iodine. So and their thyroid function still was, off the scale. So we've arranged for them to have an emergency thyroidectomy. They came in for Lugol's iodine to try for a week prior to their surgery to try and get their thyroid under control, even transiently. But I spoke to the anaesthetist and said, you need to cross-match this individual, need to have some beta blockade on board, just in case they start having problems because of these intraoperative risks. What doses do you use of the various medications? This is a table. I'm not going to go through it in detail, but you think about the standard doses that you would normally use for standard thyrotoxicosis. So PTU, you could use 200, 300, 400, maybe going up to 600 milligrams a day, but actually you potentially use slightly more in thyroid storm. Similarly with carbimazole or methimazole, usually you use 30, potentially 40 milligrams of carbimazole a day, but actually you can go up quite high on the doses should you need to for the short term to try and get their thyroid function under better control and get them out of the thyroid storm. If you want to inhibit the thyroid hormone release, as you can see here, you can use potassium iodide. Literally, you're talking about drops of potassium iodide. Similarly with Lugol's iodine.
What can I do for you? I am. Yeah.
Similarly, drops of Lugol's iodine. Propranolol, you can see intravenously, esmolol, and so on. And the steroids, again, usually IV, 100 milligrams QDS, often a standard dose for many emergencies in endocrinology, but that's what you would be doing. And dexamethasone, again, 2 milligrams 4 times a day, which is a very, very large dose. And a standard dose of paracetamol, 1 gram QDS. So, and standard dose of cholestyramine, as you can see there, and lithium carbonate, which is a slightly high dose compared to the doses used in when necessary for people who've got psychiatric diseases. Let's move on to myxedema coma. So this is potentially slightly more common than thyroid storm, partly because it's, people present with hypothyroidism much more commonly. And of course, there are many different reasons why people can present in this condition. It is very rare, but it is more common in women, as you can see. But it does have, again, an appreciable mortality, partly because of the delay in the time that it's taken to come to medical attention, but also because it takes so long, potentially, for people to recover. But the metabolic and systemic effects of myxedema coma are also quite profound, that don't recover very quickly, and if they're not treated, can lead to an appreciable mortality. So once again, what are the precipitants? Untreated hypothyroidism, either because it's never been diagnosed and the individual's never gone to seek help and they just thought, well, this is them, I'm just getting old and I feel tired and a bit, putting on a bit of weight, or they've had some treatment such as radioactive iodine, or they've had the thyroid removed for whatever reason, and it's not been treated appropriately or not been treated at all. Rarer causes, of course, people who are unwell can develop hypothyroidism. So as you see here, UTIs, pneumonias, common things, trauma, and previous surgery or strokes, not necessarily primarily affecting the thyroid, but affecting the ability of the individual to treat their own hypothyroidism, if that's what it is. And there are a number of other drugs that interfere, as you can see listed there, which could cause hypothyroidism. Amiodarone, of course, is one we all recognize. So what do you need to do? The simple thing is you need to do the thyroid function test and know what the etiology could be. Of course, it's all in the history. Once again, you're taking a good history, either from the individual or collateral history if you can, and looking at the downstream effects. So you know, hopefully from your textbook reading, that if you've ever seen one, that these individuals can present with quite a profoundly low sodium, 120 or lower. They can present with hypoglycemia. Liver enzymes can be really deranged. Their cholesterol and total cholesterol and LDL can be high. And of course, that's one of the things you always need to measure when you see somebody with hypercholesterolemia, is check their thyroid function. We all know that. They can get rhabdomyolysis, so they get a high creatinine kinase. And you know that they can become really quite profoundly neurologically impaired. They can really be quite slow and I won't use the word demented, but become really quite profoundly obtunded is better. Serous cavity effusions with pericardial effusions, pulmonary effusions, and of course ascites, and leading to multi-organ failure. And you need to be aware of all of these things, and these individuals often need to have echocardiograms, chest x-rays, and ultrasounds to find out what's going on. The neurological features can be due to the severe hypothermia, of course. As I've said here, why do they get that? The reduction in blood flow to the brain, hyponatremia, and as we all see that from a variety of different causes, not just hypothyroidism, but actually we know the neurological impact of hyponatremia, severe hyponatremia. And of course, as I mentioned, depression, as you see, hallucinations, paranoia, peripheral motor and sensory neuropathies. And if it's really extreme, they can get seizures. The cardiovascular impact, let alone the pericardial effusions, but also reduced inotropic activity. So they get heart failure because their heart is not pumping. Peripheral vasoconstriction and bradycardia, as you see there. And because they're cold, you get these characteristic J waves. And I'm sure many of you will have worked in A&E departments and seen this. They come in for hypothermic for whatever reason. And certainly from my own experience as a medical registrar, that when you warm these individuals, there is a huge risk that they will develop an arrhythmia as they get to 34, 35 degrees, that they develop an arrhythmia such as torsade de pointe, and they need to be kept an eye on. Their electrolytes must be, optimized to prevent this from happening. But all of these issues can, of course, lead them to having severe cardiac compromise, hyperventilation, and pleural effusions, and of course the big tongue. You can't ignore that. If they've had it for a long time, it can actually obstruct their upper airways, and you may need fairly swift anesthetic help. When it comes to the renal and adrenal considerations, you need to, of course, be perfusing their renal function. They could have a low cortisol, which could lead to a failure to clear free water. And of course, you need to ensure that they are given hydrocortisone, and I'll come back to that, when you treat their profound hypothyroidism. So you obviously can have low sodium and low glucose. Similar to the thyrotoxicosis, there are scoring systems out there. Again, whether you use them or not is up to you. Certainly most of the time I've not found them useful when we've seen them, because you look at them and you go, this person's cold and they're not well, and you can make the diagnosis. How do you manage them in the last few slides? Well, on an intensive care unit, ideally, because these people are in danger. Of course, it's airways, breathing, circulation. I've told you about the big tongue. You may need fairly swift anesthetic support. You need to warm them very slowly, often using the thing called the bear hugger, circulating warm air, warmed fluids, intravenous corticosteroids before you give them thyroxine. And of course, you treat their precipitants. How do you replace their thyroxine? Well, you can these days get intravenous levothyroxine. So the doses are, you give them a loading dose. And as we all know, it takes quite a long time for the levels in the blood to reach a steady state. So you do need to give them the standard doses, either orally, as you see there, 1.6 mics per kilo per 24 hours, or 1.2 if you're giving it IV, T3 also can come as IV or orally, which you can give as either as NG, and you can see the doses there. But in those people who've got cardiac compromise, in those people who are elderly, you do need to think about the lower doses, just as you would if you've got somebody who has got standard hypothyroidism. So with that, ladies and gentlemen, I've got a few minutes over, a few minutes of time. I hope you found that useful. Over to you, Amir.
Thank you so much, Ketan. Really nice and helpful summary of both the science and the practice management tips. Dr. Felicity Kaplan has asked, are we right in thinking that there is no national or SFE guidelines for the management of thyroid storm? If not, can someone take this on, as it would be very useful for trainees on call?
I think I'm not aware of any, is the honest answer. I don't think SFE have got one for either hyperthyroidism or hypothyroidism. And I agree it would be. Certainly I've been in my institution for a long time and as a registrar before that, and each institution had their own little guideline on how to manage thyroid emergencies. So I think it would be an idea, and I can certainly take that back to the SFE to say maybe that's something that we need to think about as a guideline person. Yeah, no problem whatsoever.
Thank you, Ketan. I've never been able to access IV on call, but you said that it's available.
It is available. Yes, it's being advertised in a variety of different journals these day and age. So I think it is available, but I haven't looked at the cost, but I suspect it's a huge cost, and therefore I would much suggest that if you can get liquid down an NG tube if you need to, because it's going to be cheaper.
Amazing. Thank you very much. Welcome, Professor Karim Meeran, who is going to talk about management of Graves' ophthalmopathy. Over to you.
Thank you very much. Right, so as always, I like interaction, and I want you to all vote for true or false, really, whether you think thyroid eye disease, Graves' ophthalmopathy, is definitely made worse by smoking. Just arrived after that little break. If you could take a picture of that. I've got a few questions, so this is just the first warm-up question. Okay, let me do a quick countdown. 10 seconds. Okay, so the question is thyroid eye disease definitely made worse by smoking? Okay. Okay, the answer is yes. Okay, it definitely is. There's no question about it. There's good randomized data that I will show you in a minute. So that's an important statement. Next question. Radioiodine is absolutely contraindicated in patients with thyroid eye disease. Is that true or false? So you can, if you haven't joined yet, please do join and answer that question. Do you think this is true or false? Radioiodine is absolutely contraindicated in patients with thyroid eye disease. Okay, 5 seconds. Yeah, that is false. Okay, and because if you've got a very toxic patient, absolutely means you can never use it. The risk of it getting worse is not zero. Okay, but it's not absolutely contraindicated because many patients benefit from radioiodine with or without thyroid eye disease. Okay, and not all of them will get worse. And there are ways to avoid it getting worse by using steroids, as I'll explain. Okay, so even if you've got someone who's got bad eyes, it's a good treatment. Okay, I know that people worry about it and shift away from it, but the risk is actually quite small. Okay, and third question, I'll just move this forward quickly. Patients who develop postoperative hypoparathyroidism can never be discharged. So what do you think of that? Okay, so this is my last question of this bit, but I've got more questions coming, so it's really worth joining if you haven't joined yet. So get your phone out if you haven't joined, and please click that QR code and then join and then answer the question. So if you've got a patient who has surgery for their Graves' disease and develops hypoparathyroidism, can you never discharge them? Is that true or false? Okay, and I've got 126 votes. Let's give you 10 seconds. Okay, well, actually, that is not false. Okay, you can't discharge patients with hypoparathyroidism. In the UK, there are GIRF guidelines that say we must follow these patients up for life, and the guidelines also state how often we should see them and what level of counts we should run them at. So in fact, that is true. Okay, so most of you got that wrong. You think it's okay to be hypoparathyroid, we can discharge you. So that is not the case. A very important point. Okay, so let me just tell you a bit more about why this is a problem. So this is the European guidelines we're going to go through on Graves' orbitopathy and clinical practice and how to manage patients with Graves' orbitopathy. Now, as you know, very briefly, with a quick introduction, it's an autoimmune disease, as Graves' disease, and you've got antibodies that bind to and stimulate the receptor TSH in your thyroid gland, and that receptor causes the thyroid gland to get bigger, so it's a smoothly enlarged thyroid, and also causes activation and therefore hyperthyroidism. You also see exophthalmos in some people, and you also see preaxial myxedema, also in some people. All of these are autoimmune phenomena. Those bottom three green things are autoimmune phenomena. But if you look at it, right, what happens to patients is in most patients who do get eye disease, first of all, they become hyperthyroid. Then about 1 in 3 only develop eye disease about a year later, okay? So there's a time lag. Sometimes the eye disease happens first. So we've got some patients who don't come to see us. They see the ophthalmologist saying, I've got swollen eyes, and then they do some imaging, and then they go, aha, you've got Graves' disease. But, oh, that's odd, you've got normal thyroid function tests. And then sometimes, maybe 5 years later, they do become hyperthyroid. Now, why am I saying this? What this means is the antibodies that cause eye disease must be different to those that cause hyperthyroid. Because if they're the same antibody, if you just measure them, they would all happen at the same time, but they don't. So there's the first error we're making. We're looking at the wrong antibody. Now, we don't have an assay for the right antibody. We don't even know what it really is. There's some people doing research that are close to it, but we haven't yet got the right antibody. But there's an important point here, and that there's different antibodies causing different signs, okay? So here's the important statistics, okay? First of all, in patients who have got thyroid eye disease, 90% already have had Graves' disease in terms of thyroid disease, okay? Not 100%, but 90%. Some people get eye disease first, okay? And if they just present with exophthalmos with normal TFTs, only 25% develop hyperthyroidism in the next year, okay? Half of them take 5 years to develop hyperthyroidism, so they're unlinked, okay? Now, you see patients, if you're an endocrinologist, with Graves' disease first, and only 1/3 of them will go on to get eye disease. Okay, so here's plenty of evidence that the autoimmunity that causes eye disease is distinct from that causes hyperthyroidism. Now, of course, there's lots of ways of scoring these people, and you can see conjunctival redness, edema, proptosis, which is evidenced by the fact that the swelling is below. Okay, if you can see, proptosis is where you can see the white of the eye below the iris. Above is lid retraction. Okay, so it's an autoimmune disease and you have smooth uptake in the gland. Okay, preaxial myxedema accompanies only 4% of thyroid eye disease, so much rarer, also caused by an antibody that stimulates the growth in front of your shins. Okay, so it's a different antibody. And the association of this has an association, not causative, of a poor prognosis for the eyes. Maybe they've got a more aggressive immune system. Okay, that's very simplistic, but essentially it's a different antibody. Okay, and this is your preaxial myxedema. Now, there's a separate thing that we should think about, which is what thyroxine does to your sympathetic nervous system. Okay, of course, as you know, it activates it. And what it does is it doesn't make more adrenaline, it makes your beta receptors, this is T3, makes your beta receptors more sensitive to the ambient level of adrenaline. So if you are at rest and you do a little bit of exercise and your noradrenaline goes up a tiny bit, you can feel it, because you're very sensitive to the normal rise in adrenaline. Therefore, it looks like you've got sympathetic activation, okay? You're overactive on that front. So the features are tachycardia, palpitations, tremor in the hands, and lid lag. So lid lag, which is an eye sign, is not a feature of Graves' disease. It's a feature of an overactive thyroid gland. Okay, so if anyone becomes very hyperthyroid, it will make their eyelid be held back slightly. Okay, so this is a question that I was going to ask you, but in fact, well, why don't you have a go? Take a picture of that, or if you can see the question. Let's just see if I can get it. Yeah. So, what causes lid lag? Okay, now I've got a video here. This is somebody who doesn't have lid lag. The eyelids come down very nicely. Now, this is me. It's a bit grainy maybe on Zoom, okay? But we'll zoom into it and you'll have a better view in just a minute of this patient who is following my finger. I'll just zoom in now and you can see that the eyeball comes down, the lid is held back. I'll do it one more time, okay? The eyeball comes down fast and the lids are held back. I don't know if that projects very well at home, depending on your internet connection, because it's moving. I'll do it one more time just to be clear. See, eyeball comes down, lid lag, and there. Okay, so the lids are held open just for a second, okay, by, move this forward here. Oops, yeah. So lid lag suggests hyperthyroidism, and it's caused by sympathetic activation, okay? So here's a question. Here's a patient who's got a nodule. I won't ask this, in fact, I'm going to tell you, right? This patient is hyperthyroid because of a nodule that's releasing thyroxine. What eye signs will you see in this patient? Okay, and the answer is you will see lid lag, okay? It's not autoimmune. There's a single toxic nodule. It's making too much thyroxine, and therefore there's no exophthalmos, but there is lid lag because that's not a feature of Graves' disease. So just be careful when looking at patients' eyes to distinguish those things. So getting back to Graves' disease, okay, it is first of all, in a patient who's got unilateral exophthalmos, okay, it is a common cause because thyroid disease is much more common than the other causes of unilateral exophthalmos. Okay, it can be asymmetrical, and so everyone worries about a retroorbital tumor. But you do an MRI orbits, and it's obvious that the patient's got Graves' eye disease. How can you tell? Graves' eye disease causes the inferior and medial rectus to become swollen. So if those two muscles are enlarged on an MRI, it's very likely to be Graves' orbitopathy, even in a patient who has not got hyperthyroidism yet. Okay, so that's a key feature looking at the MRI of the orbits, medial and inferior rectus swelling. More common in females like Graves' disease, like all these autoimmune things, and smoking definitely worsens the outcome. Okay, now what happens in Graves' orbitopathy? We don't fully understand it, but we know there's an antibody involved. We know there's inflammation of the muscles, so there's definitely growth factors present. It seems to increase the secretion of glycosaminoglycans. The muscles enlarge a lot and sometimes may compress the optic nerve, which causes sight-threatening disease. You also get some water retention by osmosis, and the fat also hypertrophy. So several different parts of it cause the features that you see in this patient who's got exophthalmos. And if you do an MRI orbits, you can see the medial rectus is much more swollen. It can affect any muscle. This is the normal optic nerve, but the medial muscle being swollen is a key feature of Graves' orbitopathy. Okay, there's the orbits. So there's an inflammatory stage, right? And of course, if you catch the patient when they're very inflamed, very active, then drugs work. Anti-inflammatory drugs work and the patients get better. But if you miss that inflammatory phase and it's inactive, then anti-inflammatory drugs like steroids do not work. Now, one of the problems with doing trials is that if you catch a patient in this point here, when they've got a very active inflamed eye, and you give them placebo, it will look like they're getting better into the inactive phase. So there's a really important point about doing research. You need to do proper blind randomized controlled trials to prove that drugs work, because they'll get better by themselves to some extent. So if you catch them very early and reduce the inflammation at the start, you will make a long-term difference. It's really important to see them very quickly and very early. Okay, once they've got the fibrotic stage, it's not a medical problem anymore. You can't use steroids. You'll need to get your surgical colleagues to maybe decompress the orbits. Okay, so the soft tissue inflammation, then lid retraction, then proptosis, and then if they're unlucky, they'll have an optic neuropathy, which might cause a restrictive myopathy. And this is basically where you can't look up easily because fibrosis of the inferior rectus causes reduction in movement. It looks like a superior rectus palsy, but in fact, it's fibrosis of the inferior rectus. Okay, and as I've said, the inferior and medial rectus are the most commonly affected. Okay, now if it's very severe, then you can get exposure keratopathy and corneal ulceration. So that's another important thing to think about. Give the patient drops to make sure that they keep their cornea not dry. So when you're really in trouble, okay, and this sometimes is bad luck, depending on the shape of the orbital wall, but you can get pressure on the optic nerve, which is sight-threatening, and therefore it's an emergency, and you need to use very high-dose anti-inflammatory drugs, very high-dose steroids, and other drugs such as MMF, okay, mycophenolate, in order to really aggressively suppress the immune system. So the opticians use very, very high-dose steroids and things, unlike us. It affects about 6% of patients, and this compression of the optic nerve can threaten vision, okay? Impair central vision, which is really crucial. Okay, sometimes, well, in fact, always affects one eye, and therefore the patient won't notice, so they've got to keep checking. So if you think they're at risk, if you assess the patient and the ophthalmologists think they're at risk, they will say to the patient, look, you should check that you can see with each eye every day, just to make sure there's no swelling behind the eye that's pressing the optic nerve. Okay, and here's some worse examples of a very, very severe swelling pressing on the optic nerve here, which is going to cause problems with the patient's vision. Okay, so definitely, I'm going to say smoking worsens the outcome. And of course, how bad is radioiodine in such patients? So let's look at the best randomized controlled trial, okay? One of the problems, as I've said, is that the inflammation gets worse, and quite often, if you have Graves' disease, your eye signs start 1 year later in all of the patients, right? So let's say I have Graves' disease, and I'm treated with carbimazole or surgery or radioiodine. 1 year later is when 1 in 3 patients get eye disease, and whatever you've given them, they will say that caused my eyes to get worse. So then the question is, how do you know that radioiodine definitely makes it worse compared to the other treatments? Because many patients get worse about 1 year after any treatment that they've had. Okay, there's a really important background to this. So here is the best evidence. It was published over 20 years ago, but it's a very good study and it stands today. And they took 150 patients in 3 groups. All of them were given antithyroid drugs, and then they were randomized to 3 things: either radioiodine or radioiodine with some steroid, okay, prednisolone, quite a high dose, tapered over 2 months, or group 3 were given titration methimazole. We'd use carbimazole. It's the same thing, really. Okay, so 3 groups: radioiodine, radioiodine with steroids, and methimazole. So here is the outcome, right? So in dark is the ones who got worse, and in white is those who improved. So here you are. There's no doubt that of those 150, 23 of them got worse with radioiodine, okay, compared to only 4 with carbimazole. And this is a randomized blind trial. So I think that is fair. That's a real problem, okay? But notice that if you give the radon patients prednisolone as well, nobody gets worse. In fact, 50 of them get better because steroids make the inflammation go away. So there you have it, really. The key point is you can prevent the eye disease by giving prednisolone at the same time as radioiodine. Now, it's prophylactic, so some patients won't get it anyway. So we're giving people hypertension, diabetes, and the things I hate about steroids. But if it makes the risk fall that much, it's worth thinking about. It's not the huge doses they use, okay? These are fairly medium doses, 20 milligrams for about 2 weeks to start off with. So not nothing, but it's not the very poisonous doses that we see sometimes used by them. Okay, and some people with antiviral drugs also get better, so there's a good thing. Now, I then wanted to really dig into the data, and I reread the paper very carefully, like you should, including the discussion. And then you can see 17 of these patients actually already had some eye disease, only 6 of them were new, okay? And importantly, in some of them, the worsening of the eyes lasts for 2 or 3 months. In other words, it was transient. Okay, it was persistent in 8. So there's no doubt it does cause a problem, but the number is much smaller because everyone thinks it always causes eyes to get worse. No, only a small proportion of people get worse. And if you use prednisolone, that doesn't happen. Okay. The other thing is smoking definitely makes it more likely for your eyes to get worse. Okay. And therefore, in a smoker, I'd be more worried than in a non-smoker. So a quick summary of what I want to my take-home message, which is there's no doubt that it does make radioiodine makes your eyes worse, but it's not. I mean, if you look at this, over 100 people did not get worse. Okay. Of those that got worse, most were smokers. So that's 19 of the 23. Of the huge number that did not get worse, half were non-smokers. Okay, so if you look at a prevalence kind of map, you can see that those who get worse are mostly smokers compared to non-smokers. They had 67 non-smokers, of whom 63 didn't see any worsening. Still, I'm not saying it's not risky. There is some risk, but it's much less. So let's say it's about, let's say 6 to 10% even that your eyes will get worse. That means 90% won't, okay? Now, to some people, I admit that a small worsening in the eyes is absolutely terrible, and it does worsen it in some people. So if they're worried, use a course of prednisolone to minimize that risk, okay? So this is my quick summary then. Eye disease gets slightly worse, but mostly in smokers. It's persistent in a small proportion of them. A majority are not worse in the long term, and a short course of prednisolone prevents this even in smokers. So it's a balance of discussion. It can cause it to be worse. We can give you a drug that's got its own side effects, but hopefully will prevent that. Okay, and then Bartolena, who wrote that paper, then some years later, did a quick summary of how to manage such a patient. And he's got a patient who smokes 10 cigarettes a day. He's a smoker who's got Graves' eye disease. And he goes through all the options, but he does include radioiodine therapy. And he says you can give radioiodine in between the steroids. So these patients getting intravenous methylprednisolone for bad eyes and also radioiodine for their thyroid. Okay, so it's not out at all. And it's something that you should all think about. Because remember, the NICE guidelines do have radioiodine at the top of their treatment. And the ophthalmologists are very against radioiodine, and I'm trying to redress that balance a bit, okay? I won't go through this paper in detail, but a meta-analysis, this says basically the same thing. You can use it, and just watch out for the risk. Now, let me tell you a bit more about the treatment. So, this is a very good guideline-driven paper, and they've put down where there is evidence. So first of all, it's pretty clear, even in mild disease, you should tell all patients to stop smoking because it actually makes their eyes less bad. And funnily, patients who smoke and they're told you get a heart attack, they carry on. But if their eyes get worse, some of them stop because they don't like the effects on their eyes. They're so upset by that. You should try and make them use thyroid as quickly as possible, and radioiodine is a good way to do that. And then you can use steroid prophylaxis, okay, either high dose or low dose. So between 20 and 40 milligrams to start with daily for about 2 or 3 weeks and slowly withdrawn over 6 weeks. So this is prophylaxis, okay? This is people who've got either no or mild eye disease if you want to absolutely prevent any risk. So the treatment for most people, if it's mild, is do nothing and observe. But you need to look out for it's moderate or severe and look out for post-inflammatory complications. So the first thing is to stop smoking and normal TFTs. That's what you'll do in these mild patients, okay? Okay, so this is a patient now who's moved from being normal to having mild Graves' orbitopathy. So there's a whole page in the guidelines for each of these stages, okay? So you say to the patient, don't smoke, treat their thyroid dysfunction, avoid hypothyroidism, so don't over aggressively treat them because there's some fear that having a high TSH makes the eyes worse, and then refer to the combined eye clinic and warn the patient they might get dry eyes. There is some evidence for selenium, so give all these people selenium orally and give them some artificial tears. So basically, they're not giving them anything more aggressive. There's no steroids on this, unless on the right-hand side it says they've got a markedly impaired quality of life. What does that mean? It means the patient's really upset by the mild eye disease. So in terms of vision, not affected. In terms of function, it's not affected. So most people would say, I don't mind, but there are some people who really can't bear the appearance and are very upset, and they want to have and should be given dangerous drugs, let's say, okay? Immunomodulation, the same treatment we give the bad eyes. So in other words, the point is if the patient's upset by it, there's a reason to be aggressive. Tell them the side effects, okay? And tell them the risks and so on. Now, if it gets more severe and you are worried about either vision or there's a lot of inflammation, then the same sort of things apply on the left-hand side, avoid all the problems. But the treatment you give is much more aggressive, okay? So high-dose methylprednisolone, 500 milligrams weekly for 6 weeks, and then 250 milligrams weekly for a further 6 weeks, and high-dose mycophenolate. So really flatten that immune system in order to reduce the eye inflammation, okay? And you can, if you can't use mycophenolate, you use an even higher dose of methylprednisolone instead. Okay, and basically you need to find some way of attacking the orbital TSH receptor, and that is done with this drug. So this is a steroid-sparing agent. It isn't really used in the UK because it's so expensive and there's very few cases. It is under trial, so some hospitals have access to it free of charge, randomized controlled trials that are sponsored by the drug company, but it's been proven to work, and it seems to be quite effective. We can't afford that in the UK, teprotumumab, and so in the UK, when we get second line, we are using tocilizumab, which is available, still very expensive, but available for these patients, okay? So these very second line treatment is much higher dose methylprednisolone, add in oral prednisolone or cyclosporin. Think about orbital radiotherapy with high-dose steroids, and then these three new monoclonal antibodies. The only one which is really available to us is tocilizumab and rituximab. And then if it's sight-threatening, then you have urgent referral, and essentially, if very high dose, this is 1 gram daily, so very, very high dose methylprednisolone, and if it's not better within a week, you decompress it, you get the surgeons involved, and you go for urgent orbital decompression in order to save the pressure on the optic nerve. Okay, that's a very important thing to bear in mind. Not many people go down this line, but there are people who, if their vision's threatened, they need to have surgery, and you need to get them seen very quickly. You can start with high-dose treatment, but get them seen really quickly, because if this doesn't work, they're going to lose their vision. Okay, so moderate to severe is systemic steroids. You can use oral, but IV methylpred is what the guidelines suggest because it's evidence-based. And this is our standard treatment, in fact. IV methylpred, 500 for 6 weeks, then 250, and add in oral MMF. Orbital radiotherapy is less and less favored with new drugs, very delayed effect. Some don't respond at all. It's got side effects. Some respond within 6 weeks, but it's moving downhill as we get more and more better treatments. So think about these options then, because the options are drugs for life, surgery, radioiodine, and which would you choose? Okay, and the point I made earlier is that the guidelines say that for all patients, we should think about using radioiodine early and first. It cures you, it gets you off drugs, and if you're a young woman want a pregnancy, then you need to have the treatment early so that you are treated and cured before you become pregnant, and then you won't need drugs. Okay. So radioiodine and Graves' eye disease, it's a very good treatment. Patient choice is important, and therefore I think it's very important that we get informed consent, explain to them that radioiodine has got benefits and risks. The ophthalmologists often say, don't have radioiodine, go and have a thyroidectomy, but they don't see the complication that we do of hypoparathyroidism, which, as I said at the start, basically means that you're patient forever. Life without parathyroid is absolutely terrible. Okay, they're hypocalcemic all the time, and it's very difficult to manage. So I'm not a fan of thyroidectomy in Graves patients because a 4% risk of hypoparathyroidism is a lot worse than a 4% risk of mild ectophthalmos, maybe severe in 4%, but it's a balance. It's not like radioiodine is bad for eyes because the surgery is also bad, and therefore it's something to be discussed in an MDT clinic. Okay, look, it's 29 past. I better stop and say thank you all very much and take any questions.
Thank you very much, Professor Meeran. Very clear as ever. So, couple of questions quickly because we're running out of time. What's the mechanism behind smoking exacerbating Graves' orbitopathy?
I wish we knew. We definitely don't know what the mechanism is. There definitely is that very strong association, and in all of those trials, it does make it worse. Mechanism is not clear. We also don't know how long you need to not smoke for.
Thank you. How do we know if thyroid eye disease is inactive or in the resting phase?
Okay, so there's a CAS score, which I haven't talked about because of lack of time, but effectively there's a scoring system where you look at the amount of conjunctival edema, the redness, it scores out of 7. And if you look at those things, if they've got inflammation, what you really need to do is have a combined clinic. So we have a clinic with the orbitopathists and they do the assessment for me. We just do a quick screen, but actually there's a very, very carefully worked out, there's 2 or 3 different systems that you can use to work out the amount of inflammation.
Thank you very much.
It's clinical though, okay, it's clinical, there's no blood test.
Thank you very much. In the interest of time, we need to move on. Thank you very much. And the talks are all recorded and will be made available on the Imperial Centre for Endocrinology website. So our final talk is going to be given by Dr. Florian Wernig. It's my pleasure to welcome Florian, who is going to talk about management of medullary thyroid cancer.
Thank you, Amir. Let me just see if I can share my slides. Apologies for that. So for the next 20 to 30 minutes, I'm going to talk about current strategies and future directions in the management of medullary thyroid cancer. I want to start with a case. So a 68-year-old man who was blue lighted to the emergency services with shortness of breath, cough, and fever. His past medical history was notable for type 2 diabetes, hypertension, COPD, and schizophrenia. He was a heavy smoker. On examination, he was overweight, clubbed, and had severe proximal myopathy. And when his first biochemical results were notable for severe hyperkalemia with potassium of 2.3 nanomoles per liter and metabolic alkalosis. He required a lot of potassium, intravenous potassium infusions to normalize his potassium. And further biochemical investigation showed that he was severely hypercortisolemic, failed to suppress to dexamethasone suppression, and his ACTH levels were markedly elevated at 275 nanograms per liter. Further investigation showed a normal pituitary, and a CT of his chest, abdomen, and pelvis revealed bulky adrenal glands, but also bronchovascular nodules and a 2 centimeter supraclavicular lymph node. He went on to have an FDG PET scan, which showed low-level uptake in the supraclavicular lymph node. Given his smoking history, a bronchoscopy was planned, but he also underwent with some delay a biopsy of the lymph node, which showed histologically a well-differentiated neuroendocrine tumor. And it was suggested that it could be either of lung or thyroid origin, and a serum calcitonin level was recommended. His serum calcitonin was more than 38,000 nanograms per liter, and a further workup and immunohistochemistry confirmed the diagnosis of medullary thyroid cancer with presumed ectopic ACTH secretion. So I want to give you some more background about medullary thyroid cancer. You all know that medullary thyroid cancer is a rare and aggressive neuroendocrine tumor arising from parafollicular C cells. and it accounts for about 2 to 4% of thyroid cancers, and it perhaps even less with the rise of the incidence of papillary thyroid cancer, but it has a disproportionate high mortality rate given its rarity. In recent years, there have been huge advances in molecular biology and targeted therapies, and they have significantly transformed management. Medullary thyroid cancer can be hereditary or sporadic, and 75% of medullary thyroid cancers are sporadic. They do, however, harbor somatic mutations, such as somatic web mutations in 45 to 70% of patients, and other mutations such as RAS mutation in 60 to 20% of patients. About a third of medullary thyroid cancers are associated with a familial syndrome, namely MEN2, MEN3, formerly MEN2B, and familial medullary thyroid cancer, which is now regarded as a variant of MEN2. And all those patients have a germline RET mutation. Now, medullary thyroid cancer can present in 5 different ways, and most sporadic cases present with a neck mass. And it can also present with a mass from metastatic disease, mostly in cervical lymph nodes or distant metastases. Some medullary thyroid cancers first present with symptoms secondary to elevated calcitonin levels, such as flushing or diarrhea. And very rarely, like in the case I presented earlier, it can present as ectopic Cushing syndrome. And then there's those cancers associated with a familial syndrome who are detected after familial screening. So once a medullary thyroid cancer has been diagnosed, the diagnostic workup consists in biochemical assessment with biochemical markers such as calcitonin and CEA, imaging with various imaging modalities we're going to talk about more later, and genetic testing for RET mutations, which is essential and mandatory. So I'm going through those steps now one by one. I'm going to talk a bit more about calcitonin, so the main tumor marker for medullary thyroid cancer. Calcitonin is highly sensitive, and C cells do not lose their ability to produce calcitonin when they become neoplastic. It is a 32 amino acid polypeptide. It is highly sensitive, but less specific, which means that there is a false positive rate, and certain conditions such as chronic renal failure, hyperparathyroidism, chronic autoimmune thyroiditis, small and large cell lung cancers, prostate cancer, mastocytosis, or enteric or pulmonary neuroendocrine tumors can give rise to elevated calcitonins. It's also a very difficult analyte, and it's a very unstable analyte for the laboratory. So it's only stable for about 2 hours at room temperature, and therefore sample handling is crucial. Correct sample handling is crucial. Sometimes heterophilic antibodies can give rise to falsely elevated calcitonin levels. And the opposite can be the case if calcitonin levels are extremely high, then this so-called hook effect can take place, that levels are falsely low. It is important to actually know what, to know your local assay, how calcitonin is being measured. It was previously recommended that patients with a calcitonin of more than 10 picograms per milliliter should undergo confirmatory testing. So this is a very old publication from 1988. But later on, if you look at this slide, so these are different calcitonin assays from A to E. And what you can see is that all those assays, within all those assays, there are normal subjects with calcitonin levels of more than 10 picograms per milliliter. So it's about 3 to 10% of normal subjects with higher calcitonin levels than the previously proposed cutoff. And there is also gender-specific differences in that men have significantly higher calcitonin levels compared to women. This is believed to be due to the higher C cell mass in men. So that's why it's important to know your local assay, to know your local cutoffs. And what you can see here is that the imperial cutoff, for instance, for men is more than twice that cutoff for women. It is important that you always use the same calcitonin assay if you want to diagnose medullary thyroid cancer for postoperative follow-up and monitoring, and we talk about this later. So preoperative calcitonin levels can influence surgical planning. And what you can see here is that if you have calcitonin of less than 50, there's a very low likelihood that patients will have lymph node metastases and the cancer is just confined to the thyroid. The likelihood of having metastatic involvement increases with increasing calcitonin levels, and levels of more than 1,000 strongly suggest distant metastatic disease. It's controversial that patients with a calcitonin level preoperatively of more than 200 picograms per milliliter should also have a contralateral neck dissection, along with a total thyroidectomy and ipsilateral dissection. And I'm not going to talk too much about surgical management because we are endocrinologists and it's not the main purpose of this talk. But what I would like to highlight is that outcomes are much better in high volume surgical centers. And the recurrence rates are much, much lower if carried out by an experienced surgeon in a center. In addition, it is mandatory that you measure metanephrine levels to screen for pheochromocytoma if the VET status is not known. Postoperative evaluation, if calcitonin is less than 150 picograms per milliliter, it suggests that the disease is just localized. There's still persistent disease, but localized disease. If more than 150 picograms per milliliter, there's a suggestion that patients may have distant metastases. And imaging for residual disease and dynamic risk stratification should follow. So how are we going to follow up patients with medullary thyroid cancer after they had their first or their primary treatment, which is surgery? So if the calcitonin levels are undetectable after surgery, this suggests a very low recurrence risk. In terms of follow-up, it will be a combination of tumor markers, biochemical follow-up, and imaging such as neck ultrasound. And if there's persistent elevation of tumor markers, this indicates a possible recurrence. The main metastatic sites where medullary thyroid cancer metastasizes to are the liver, lungs, bone, and also brain. And early regional lymph node spread is very common. Imaging will involve a combination of structural and functional imaging when metastases are suspected. Structural imaging is carried out when the calcitonin rises, and for the neck, we still use ultrasound. For the chest, CT is the best imaging modality. Liver MRI is the most sensitive imaging modality to detect liver metastases. And we also use bone scintigraphy to detect bone metastases. And it's going to be a combination of various imaging modalities to improve detection accuracy. Functional imaging, it has emerged that gallium-68 PET-CT seems to have a higher lesion detection rate compared to FDG PET-CT, which is more widely available in most hospitals. But the most sensitive imaging modality for residual or recurrent disease seems to be 18F Doppler PET, but unfortunately it only has very limited availability. So the choice of imaging selection will depend on disease status, but also local availability and clinical judgment. And often it is a combination of PET tracers that can improve detection of residual or recurrent disease. It can be challenging to actually detect occult metastases, in particular when calcitonin levels don't rise very rapidly. So if medullary thyroid cancer is associated with a familial syndrome, most of medullary thyroid cancers will be part of MEN2, so which carries 95% of hereditary cancer syndromes linked to MTC. And MTC is often the first tumor to become apparent. 50% of patients with MEN2, as we know, develop pheochromocytomas, and about a third or less hyperparathyroidism. The penetrance of MTC is very high, with a almost 90% lifetime risk. And there is a clear genotype to phenotype correlation, which also will influence the timing of prophylactic thyroidectomy. MEN3, formerly MEN2B, is the most aggressive and early onset form of MTC with a more than 90%, almost 100% penetrance. And in those patients, it is recommended that they undergo prophylactic thyroidectomy in infancy. So this slide, which is taken from a recent review article, shows the various RET mutations and the classification or the categorization in a moderate, high, and highest risk category. And so this is from the American Thyroid Association guidelines from 2015, where patients are risk stratified according to the mutation. And what that means is that patients with the highest risk, within the highest risk category will develop medullary thyroid cancer earlier. And they also will develop metastatic disease earlier than patients with a high or moderate risk mutation. This slide depicts the postoperative follow-up and algorithm one can follow. And I want to now focus more on patients who have progressive disease and on a systemic and targeted therapy. But before that, when patients come to the medullary thyroid cancer follow-up clinic, we need to assess their nadir calcitonin levels after surgery, and it's recommended to wait for 3 months to get a true reading because calcitonin has got a very long half-life. So the 3 months calcitonin level should be the nadir level. And after that, both calcitonin and CA should be monitored every 3 to 6 months for the first 2 to 3 years. And once they become, if they're undetectable, they can be checked annually thereafter. And we all know that calcitonin doubling times strongly relate to disease progression. This is a study from a French group led by Professor Schlimberger, 55 medullary thyroid cancer patients, and they underwent follow-up with imaging, and disease progression was determined by RECIST criteria, so radiological RECIST criteria. And what you can see here is that patients who have a calcitonin doubling time of less than 2 years, 94% of those patients, so 16, would have progressive disease, whereas if the doubling time is more than 2 years, 86% of patients would have stable disease. And this is also closely related to survival. So a calcitonin doubling time of less than 6 months has a relatively poor survival rate, whereas of more than 6 months, the 5-year survival rises to 92%, 10-year survival to 37%. It is recommended to use at least 4 time points of calcitonin within a period of 2 years to calculate the doubling time. And this slide shows you the calcitonin doubling time calculator, which is freely available online through the American Thyroid Association. As I mentioned earlier, calcitonin should be measured by the same assay each time to be comparable because there's quite a high variability between different calcitonin assays. Now, if patients have progressive disease, and then it is a balance between judging whether they are symptomatic from the progressive disease or whether they should undergo treatment with targeted therapy, which also has potential side effects. However, multikinase inhibitors and the 2 approved multikinase inhibitors, vandetanib and cabozantinib, are very effective to induce progression-free survival, but they are associated with off-target toxicities. the main side effects are diarrhea, rashes, hypertension, and fatigue. And they can cause general malaise in patients, and patients generally do not like taking them. So their long-term use is really limited by toxicities, but also resistances to treatment. Over the last years, selective RET inhibitors have been in clinical use. The two selective RET inhibitors being used, currently being licensed for medullary thyroid cancer, selpercatinib and bralcetinib. And they very potently inhibit RET with much improved tolerability compared to multikinase inhibitors. They have really impressive overall response rates and very impressive progression-free survival rates. The side effects are mostly mild, hypertension, sometimes neutropenia, and very rarely discontinuation of treatment is warranted due to toxicities. There's also new research to use them in a neoadjuvant setting, so before patients undergo surgery, and clinical trials are currently evaluating long-term outcomes. So this was one of the first publications about selpercatinib in RET-altered thyroid cancers in 2020, published in the New England Journal of Medicine. And this is a waterfall plot showing the maximum change in tumor size. The upper part is in patients who were pre-treated with either cabozantinib or vandetanib. And panel P shows patients who were naive, who didn't have any multikinase treatment before then. And what you can see is that almost all patients had a really impressive response rate. And in some patients, actually, they went into full remission. So there was a 100% reduction in tumor size. In 2023, a phase 3 trial of selpercatinib in advanced RET mutant medullary thyroid cancer was published, which showed significantly increased progression-free survival, as well as significantly increased treatment failure-free survival. So this means survival until progression occurs, as well as overall survival, which was also significantly increased. So importantly, the control group received either cabozantinib or vandetanib. This was at the physician's discretion, so they weren't without treatment. So it was selpercatinib with it compared to a multikinase inhibitor. So NICE recommends cabozantinib and vandetanib for treating of medullary thyroid cancer. This was approved in 2018. And in 2021, selpercatinib was now recommended for advanced thyroid cancer with RET alterations. And in the UK, it is available after treatment with cabozantinib and vandetanib. So once, if patients cannot tolerate multikinase inhibitors, or there is a failure to treatment, if they don't respond well, then one can switch to a direct RET inhibitor. What has emerged with this new treatment is treatment resistance. And resistance can be either on-target resistance or off-target resistance. On-target resistance means it's the gene itself, so the RET gatekeeper mutations that inhibit the binding, for instance. And off-target resistant means that bypass pathways are being activated. And there's research ongoing to actually detect resistance early by doing liquid biopsies and looking at circulating tumor DNA. And future directions are to develop second-generation RET inhibitors, and they're already in clinical trial use that specifically target resistant mutations. And early detection of resistance can guide timely therapy and adjustments, and improve clinical outcomes. Back to our patient. So it was planned to perform a total thyroidectomy, but it became apparent that the tumor was too advanced to be fully resected. And you can see the surgical note, which states that the tumor was firm and rock hard, so impossible to surgically resect. So a biopsy was taken from the right thyroid lobe, and molecular genetic testing was carried out. And this patient was found to have a somatic red mutation, so which opened up more therapeutic options. So this patient was initially admitted, as mentioned earlier, with severe hypokalemia, proximal myopathy in January 2021. Ectopic Cushing's was suspected by doing more biochemical analysis. And later on, there was the supraclavicular lymph nodes, some bronchial nodules, so it's suspected lung cancer, but further analysis and the high calcitonin level confirmed the diagnosis of medullary thyroid cancer with ectopic ACTH production. A thyroidectomy was attempted but abandoned, and he was commenced on cabozantinib. But due to severe side effects, the patients did not manage to carry on, and his treatment was changed to selpercatinib. His Cushing's disease, Cushing's syndrome, went into full remission in April 2023, and he could stop a block and replace regime, which was started earlier. And it is now more than 2 years after, actually more than 3-4 years after his initial diagnosis, and he continues on selpercatinib 120 milligrams twice daily with no issues, no side effects, stable disease, and calcitonin levels within the normal range. So what you can see here is a timeline of calcitonin. So it started off with 40,000, and here cabozantinib was started. And what you can see here is that calcitonin goes up and down, so he cannot tolerate it. He stops it intermittently, calcitonin goes up again. Until 1 year later, selpercatinib was commenced, and since then his calcitonin remains well within the normal range. So I wanted to give you a brief overview about current management of medullary thyroid cancer and emerging the last developments, but also emerging therapies. So the multi-kinase inhibitors and selective RET inhibitors have significantly changed how we treat medullary thyroid cancers. There are some emerging therapies and future directions, and there are clinical trials using combination therapies, next generation RET inhibitors, PRRT, or immunotherapy. And the future directions consists in personalized molecular profiling and personalized medicine, personalized targeted treatments for those patients. And there's ongoing clinical trials for novel therapies. So in conclusion, the advances in molecular profiling and targeted therapies have significantly changed how we treat medullary thyroid cancer and therapy outcomes. And the challenge for the future will be to overcome resistance and expand therapeutic options. Many thanks.
Fantastic. Thank you ever so much, Florian. We have got one question in the chat, I think. Any value in checking calcitonin after radioactive? That may have been for the previous talk. I think it's got calcitonin in it, but it's actually not. Okay. I'm just looking at the chat. I don't think we've got any questions, which means we can finish on time. Thank you ever so much for joining us. Please remember, we're going to have 2 masterclasses in April. 4th of April, the reproductive endocrine one, and then 25th of April, a full masterclass dedicated to neuroendocrine tumors. I'm now going to share the QR code that you can scan, answer the questions and feedback, and then get your certificate immediately emailed to you. Please make sure you spell your name in the questionnaire in the way that you want it to appear on your certificate.